Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and we are pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service.
Well, I guess it's the afternoon. Good afternoon, colleagues, and thank you very much for spending your time with us today at noon. I want to first give my gratitude and thanks to all of you for being here for this hour. And I want to give my gratitude and thanks to VITALS for their invitation for me to do this presentation and hopefully have a Q&A and have a discussion together around innovation in care delivery. I'm Mehdi Shishehbor. I'm a physician, interventional cardiologist. I'm currently the president of the Harrington Heart and Vascular Institute here at University Hospitals. I came to the United States when I was 14 years old and had the fortune of going through high school and undergraduate and medical school in Florida. I then moved to Cleveland and underwent residency, cardiovascular fellowship, interventional cardiology, and then I did a sabbatical in endovascular or vascular intervention to become an expert in vascular. I have dedicated my life and my career to saving limbs. So I don't like amputations if possible. And I advocate for patients with diabetes, chronic vascular disease, and those that are at risk of losing their leg, and have committed myself to making sure that there is a lot of awareness and that there are new technologies and innovative ways, not only with devices, but through care delivery to try to save as many limbs as we can. I'm proud to say that we have an international program here at University Hospitals, Harrington Heart and Vascular Institute, and we have patients that not only come from Northeast Ohio, but from across the United States to get their care here at University Hospitals and in Cleveland. So without further ado, let me share my slides, and hopefully we can have some slides that we can share with you around our work in vascular and how we put the patient at the center, and then we could have some Q&A after that. So if you allow me, I'll share my slides here. The focus on my presentation today is going to be mainly around how we should focus and put the patient at the center of the care, rather than some of the historical perspective that's been given to us in regards to our divisions, departments, specialties, and some of the silos of medicine. So hopefully you'll enjoy it and we have a good time together. So I am in the field of vascular disease, so to kind of set the stage here for us, I treat patients that have peripheral artery disease, PAD. And these patients can be as simple as being asymptomatic or as benign as asymptomatic. They may have blockages, that they may not even know they have it, and that's majority of the patients. They could have what we call lifestyle limiting claudication. That's where they have blockages that hurts their calf muscle when they walk, and then they have to sit and rest for the pain go away. That sometimes can get even more severe to this stage where they cannot do their activity of daily living. And then the more advanced form of this is what we call critical limb ischemia, or CLTI. And these are patients that have gangrene and are at risk of losing their leg and may need amputation. So that's kind of the area where I'm going to focus today. And that's the most advanced form of the disease, where patients are at the highest risk of losing their leg, the critical limb ischemia, where there is gangrene and ulcers. So these are the kind of patients that come to me, and I apologize. I hope I don't gross anybody out here, but this is my life, basically. These are the kind of patients that come see me. These are 6 different patients. And while you're seeing their wounds, all of these patients, there is a face behind every wound here. And these are 6 patients that are at risk of losing their leg. You can imagine the amount of stress and the anxiety and the chronic care that they've been through to get to the point that they're coming to me with this kind of a picture. You can see how bad these wounds are, and they're asking us for help. These patients are sick. There is significant disease. This is a paper we published. Patients with ulcers and gangrene are getting sicker and sicker. If you look from 2003 to 2011, you see that the prevalence of hypertension has increased. Obesity has quadrupled. Diabetes has increased. Chronic kidney disease has doubled. And the rates of amputation, we call them prior amputations. So somebody having lost a leg already, now they're going to lose their good leg, has increased. So patients are getting sicker and more complicated. Unfortunately, despite the fact that this disease is very deadly, turns out by 2 years, 50% of the patients, by 5 years, 50% of the patients are dead with this condition. And the fundamental problem in these patients that come in with ulcer and gangrene, in addition to diabetes, is blood flow. You need to have blood flow to heal wounds. And many of these patients have a challenge with blood flow. I want to share a story with you because I think you will enjoy at least understanding the complexity of the care of these patients. This was a patient that came to us many years ago, came to me for a second or third opinion. The patient was a 68-year-old gentleman with multiple comorbidities, congestive heart failure, prior heart attack, myocardial infarction, history of atrial fibrillation, prior open heart surgery, and valvular heart disease. Turns out he had these wounds for over 2 years. And in many locations in the chart, they had said that the patient was non-compliant because they thought these wounds were due to swelling and edema. And they kept asking the patient to elevate your leg to remove the swelling, but the patient was not doing it because he would say, I have pain. When I elevate my leg, I have too much pain and I cannot do it. So he was also labeled in a way as being non-compliant. When we saw the patient, we did a simple test. Now, mind you, for 2 years, this test was not done. We did the test on the patient. This is a PVR test where we check the blood flow to the legs. And the first thing we noticed was that there were flat lines everywhere. There was something wrong. So then we took the patient to the cardiac catheterization laboratory to see where the blockages were. And let me walk you through this so you see what's going on. This is the groin on this side. And here we have a needle. There's a little needle going through the groin. And we're trying to advance the wire up here into what we call the aorta, this big artery here. And what we noticed was that the wire was not traveling up the way that it's supposed to go to get to the aorta. So we decided to take a picture through the needle, and we found out that this artery was 100% blocked. We then came from the wrist, and we came down the aorta, and this is our catheter here. You see a little pigtail, little catheter here. We are taking a picture from that catheter, and what we saw was that the aorta was 100% blocked. Immediately we realized why this poor man was not able to elevate his leg so that the swelling goes down, because he had no blood flow. And every time he elevated his legs were getting ischemic. They were not getting enough blood. So he was in pain. The beauty and the sadness of this story is that this is something we can fix in an hour. So right there in the lab, we got to work. And we put a couple of stents here in his arteries. We opened the blood flow for him. This was his test afterwards. But the sad part of it was that he was suffering with this condition for 2 years. And the question is, how do we innovate in delivering care so that patients like this are not left behind? How do we make sure that we work in a multi-centric way, collaborating with each other, putting the patient at the center, rather than our egos or our specialty or our department or our division, things that we have been taught throughout our careers in medicine, and focus our energy on patients like this so that they don't go along for 2 years with pain and suffering when something can be done as quick as an hour or two to save their leg and their suffering. This was the blood flow to the patient's leg after we revascularized them in the cath lab, and about 14 weeks later, the patient was completely healed. It was just a wake-up call for me, to be honest with you, that there is a lot more we can do. It's not always about the stents or the wires or the technology. Sometimes it's about the care delivery. How can you deliver the care? How can you work in a team to take care of these patients? One of the things I noticed early on was that many of these patients were not even being evaluated appropriately. This study was mind-blowing. What my colleagues did in this study, they looked at the different regions in the United States. So that's on the x-axis here. And they looked at the intensity of the vascular kind of care in those regions. Like Cleveland would be considered a very high intensity, right? There are major medical centers here that offer vascular care. So you would imagine that with all the universities and all the centers here, that there would be a significant amount of vascular care. And then they looked at the group of patients that had major amputation. This is below knee amputation or above knee amputation. And they said 1 year prior to getting a major amputation, did the patient have any extensive vascular workup? Something very reasonable, right? If you're going to lose your leg, in the year prior to your amputation, did you get any vascular procedures? Did you have any kind of a extensive workup before somebody cut your leg? And what they find is mind-blowing. They found out that between 38 to 70% of the patients had no vascular workup or procedures 1 year, up to 1 year prior to their major amputation. That means patients were getting their leg cut off without even getting a workup, a full evaluation. And things like this were very bothersome to us. We didn't like it. So I'm going to, for the sake of time, I'm going to skip a couple. I had another case I was going to show you, but I'm going to skip the case because I want to go to the more important stuff here. So what we did here was that we said, you know what, we want to change this, and we want to reduce the heterogeneity of care. So what did we do here? We noticed that, for example, at university hospitals, patients can get their care in so many different places. It's just incredible. For example, university hospitals has over 17 smaller hospitals. It's a system, it's a health system. And turns out that 75% of the care right now in the United States is offered through health system, because many of the bigger institutions have acquired smaller community hospitals. And now we have these large health systems that are taking care of patients. Well, is the care going to be the same if you go to hospital X in the health system versus hospital Y versus hospital B? Do we have consistent care? We also have a number of departments and divisions. For example, in heart and vascular, we have division of surgery, division of vascular surgery, cardiac surgery, and cardiovascular medicine. And then we have different types of doctors. We have academic doctors. We have regional community doctors. We have independent doctors. It's very complicated. How do we reduce this heterogeneity this noise, so we can work together to take care of our patients. So when it came to amputation, this is the way it was working at university hospitals before. Patients were coming through different routes. A patient could come in through interventional cardiology. They could come in through podiatry. They could come in through vascular medicine. They could come in through vascular surgery. These areas are all siloed, right? Interventional cardiologists, they work together. Podiatrists, they work together. Vascular surgeons, they work together. Vascular medicine, they work together. And these doctors, they work in silos. Sometimes they refer a patient to each other, but they never sit together, put all of their great minds together to see what's the best for the patient. So we noticed that through these silos, patients were undergoing amputation and losing their leg. So the idea was, how can we stop this? Can we change this? So when we looked at our own university hospitals, as I said earlier, there were 11 hospitals. There were 11 vascular surgeons. There were 6 interventional cardiologists. There were 6 medicine doctors. There were a number of independent podiatrists, many of them, 30, 40, 50. There were wound care specialists at UH1, and there were plastic surgeons. There was really a slew of doctors and specialties that were working, and we wanted to bring these folks together across this complex network of vertical entities. We try to create a horizontal service line to take care of these patients. So let me tell you what we did here. We created something called the Limb Salvage Advisory Council. And the way this worked was that we said, you know what? We know that we have these silos, these areas where patients are being seen for vascular disease and for ulcers and gangrene. For example, interventional cardiologists are seeing these patients, podiatrists, vascular surgeons, and vascular medicine. And they're deciding to send these patients for amputation. We are going to stop the process by creating something called Limb Salvage Advisory Council. And we're going to place this right here in between all of these folks and amputation. And we're going to mandate a second opinion for every patient that is at risk of amputation, enforcing all of these doctors to get together in one virtual space to discuss these patients before they undergo a major amputation. And if the decision is to get amputation, after all of the experts have discussed the patient, okay, fine, the patient will get the amputation. But if the decision is not to get amputation, then we can send the patient to the best team that can do the revascularization and try to save the patient's leg. Look what happened. So this was the process. We said, if you have a patient that needs a major amputation, you need to activate our coordinator. At the time we started this many years ago, her name was Tanya. So we would activate Tanya. We had an extension, a pager, an email, every venue. She would then put the team together. We would have one of our colleagues, one of our fellows, present the case, and then we would put a WebEx virtual Zoom like this meeting where we would present the case, discuss the case with a multidisciplinary team, and then make a plan. We published our work a couple years ago, and this is what we showed. It was incredible. What we showed is that amongst patients that were scheduled to undergo a major amputation, and for those of you that don't know, major amputation means either a below knee amputation or an above knee amputation. So it's a serious life-changing event. As I said, when patients get amputated, 50% of them die within 2 years. If they have gangrene and ulcers, 50% die within 5 years. So the morbidity and mortality from a major amputation is extremely high. What we showed at our own hospital was that through the LSAC program, the Limb Salvage Advisory Council, 95% of the patients that were deemed that they had no option, that nothing could be done, and they need major amputation, were able to be successfully revascularized after we discussed them in this Limb Salvage Advisory Council. 95%. And of those 95%, 75% of them, we were able to save their limb after 6 months. Excuse me, in 6 month follow-up. We now have had longer follow-up, and the result is actually persistent, that 75% of those patients that were scheduled to undergo a major amputation, we are now able to save their leg and prevent them from losing their leg. And we have now, it's been amazing, the work that's been done here by my team and my colleagues here at University Hospitals. You can see that we started this program around 2018. At that time at UH, we were having about 100 amputations per year. Since that time, our program has quadrupled in size. We see about 2,000 cases of patients with vascular disease at risk of losing their leg, like you see in this picture. Despite the fact that the program has grown by threefold and fourfold, the rates of amputations have continued to decline. So the program has grown, the complexity of the cases have grown, but the rates of amputations have continued to decline, and we believe that is all related to this multidisciplinary team of folks working together, vascular surgeons, interventional cardiologists, podiatrists, plastic surgeons, wound experts, working together to make sure that we are offering the best to the patient and preventing the patients from having an amputation. And I just want to put a couple of words here because it's not me, I'm just the messenger here tonight. It's really a group of amazing team that have come together and agreed to this. As you can imagine, anytime you want to create something like this, there's going to be a number of obstacles. And I'm sure Monica Robbins will ask us a bunch of questions related to this. But this is the leadership of our vascular center. We have a vascular surgeon, Dr. Jay Cho. We have a vascular medicine expert, Dr. Gornick. We have an endovascular interventional expert, Dr. June Lee. And we have an administrator. And this is the incredible team of physicians that work together. These are vascular surgeons, vascular medicine, interventional cardiologists that have really checked their ego at the door. They have forgotten about their specialty and their division and their department, and they have decided they want to be passionate and they want to put this patient at the center. They want to deal with this in a way that they do the best for the patient. It doesn't matter what is their specialty and what is their department. And these are some of our APPs that are doing the work. I just want to make sure I give credit to the people that are actually doing the work. And we are proud of this center and the work that they are doing. We also put together a venous center, again, for similar reasons, because there are many patients that have venous ulcers. These are a little bit different than arterial ulcers that I presented to you. So again, a slew and a group of folks that are gotten together across multiple different disciplines, taking care of patients with venous disease. And then lastly, I'm going to show you our limb salvage program. And this is the amazing team of limb salvage experts. Again, we have interventional cardiologists, vascular surgeons, vascular medicine, research coordinators, and APPs and administrators that are all working together to make sure that we are offering a patient-centric care to every patient. Our purpose and our mission is to leave no limbs behind. And we want to commit and take care of patients that are at risk of major amputation and vascular disease with diabetes, gangrene, and ulcers. So with that, I will stop sharing and look forward to your questions and any discussion you want to have around this program that we have created here, a kind of an innovative program around care delivery for the sickest patients at risk of losing their limb.
Dr. Shishehbor, thank you so much for that presentation. For me, it's a reminder because I've covered your work for so many years. And I just want to welcome everybody who has tuned in on Zoom. Again, I want to remind you, if you have any questions for Dr. Shishehbor, please put them in the Q&A and we will get to them as soon as possible. And I also want to remind everyone, he's too humble to tell you this, but there aren't many doctors who've been published in the New England Journal of Medicine within 6 months with 2 different articles. So I'm going to give credit where credit is due. We have a question over here. Absolutely amazing results achieved through a standardized multidisciplinary quality of care initiative. A major challenge in healthcare is getting physicians nationwide to adopt these types of benchmarks and standard of care practice. Are you engaging in advocacy work with CMS to mandate similar practices nationwide and trying to get it reimbursed?
Yes, that's a wonderful question, and thank you very much for asking such a thoughtful question. Because as many of our colleagues here on the Zoom know, and we are aware that a lot of these changes have to happen in parallel to policy. For example, here at UH even, we had to mandate, the LSAC activation prior to major amputation. I want to be honest with you. In the beginning, we had some struggles. I mean, some of our colleagues, not because they had a bad intention, it was just not part of the routine, and they would forget to call the LSAC. So we had to set some policies and procedures to make sure that that you couldn't undergo a major amputation without a multidisciplinary evaluation. I can tell you that I've been a big advocate of this through CMS. There are other areas that we have done this through CMS. A perfect example, Monica, and you have covered this, is TAVR, aortic valve replacement through the percutaneous approach. The CMS mandates that in order for a patient to get a TAVR, there has to be a multidisciplinary evaluation by a cardiac surgeon and a cardiologist, that you cannot do it in isolation. And I have been a big advocate, and I've even written some articles about this. And I think we need to continue the fight, that hopefully one day there would be these kind of regulations and policies, that if somebody is going to undergo a major life-changing event, like a major amputation, that there is a mandate in the chart, there is a multidisciplinary evaluation, and there's a multidisciplinary team that agrees that amputation is the right way to go. One of the challenges, just to be frank, has been that there are a lot of underserved areas in the United States that don't have multidisciplinary teams. We are lucky here, obviously, in Cleveland. There are some areas where there's one doctor for everything. It's the same doctor that delivers the baby, does the bypass, does the heart surgery. It's like they have like limited number of physicians. And one of the pushbacks has been that if we mandate something like this, we may put underserved areas under significant amount of pressure, because they may not have multidisciplinary teams and a number of experts like you do in the bigger cities like Cleveland. But those are some of the obstacles that hopefully we can overcome over time through virtual consults and other modalities that are currently available, and also having centers of excellence.
Michael wants to know, are there plans to expand the LSAC methodology to UH's referral partners in the region whose patients could benefit from care at an academic medical center?
I love that question. So that's the next front for us. It's not easy, Michael. Honestly, the biggest elephant in the room is HIPAA, if you will. Because obviously, if you're sharing information across organizations, there are some challenges with that. The second part of this, honestly, I'm sad to say, is the legal aspect of this, and the kind of resolving and dealing with some of the legal implications of this. There are not too many precedents for this. Unfortunately, during COVID, there were some laxity, if you will, in working with different organizations and different hospitals, like citywide, to do some of this kind of work. But now we are going back to those silos again. My dream, actually, Michael, is, to be honest with you, to have a citywide LSAC. So it doesn't matter where you are, which hospital. If they want to cut your leg, that there will be a LSAC activation citywide, and we would get experts from every hospital to get on a Zoom call or a conference call that would discuss the patient, because it's so easy. Like right now, we can easily show the videos and the images and the CAT scan, look at the pictures, and we can easily, it doesn't matter where you are, you could even be on vacation outside of the United States, but you can give your input and your advice about the care of the patient. So my dream is to do that. I have been working to try to make this happen, but I've had some obstacles in my way, but I don't give up that easy. So let's see what happens.
You and I have discussed this before. Is this a health disparity issue because amputation is likely cheaper?
As much as I hate to admit to this, Monica, my heart doesn't want to say yes, but the reality is that the data is the data. And the reality is that if you're African American, you are 4 times more likely to get a major amputation, and you are 4 times less likely to get revascularization. Remember, I said in my presentation that blood is the key here. People need revascularization to get blood to their wounds. If you don't have blood, you cannot heal. It doesn't matter. And the reality is that we do have a disparity here. And what I have found out, to be honest with you, programs like this, because there's so much data out there that there is disparity. Like, we don't need to know that, like, get another piece of paper, another manuscript telling us there is disparity. The question is that what are the solutions to deal with the disparity? Everybody knows there is disparity in areas. One of the solutions, in my opinion, is actually creating this program like LSAC, because a lot of our patients from underserved areas and underserved backgrounds, they don't ask for second opinion, because either they have had a family member that have had an amputation, so they think that that's part of life, like my uncle had it. These are things patients have told me, that, you know what, I didn't ask for a second opinion because my uncle had an amputation. So I thought this is the way it is. At some point, you have diabetes and you lose your leg. And the other part of it is that they don't think they have the right. They think they're going to upset their doctor if they ask for a second opinion. So by creating a program like this, you really take out the patient out of the need to ask for a second opinion, because the mandatory second opinion. And we have learned that this is actually one way to deal with disparities. I can tell you that a significant portion of the patients that have gone through the LSAC are African American.
Deborah wants to know if this applies to arm amputations as well.
Yes, luckily we don't see a lot of arm amputation. The anatomy of the arm is a little bit different than the leg. So we are very fortunate that they're not even close. Like, I can tell you that I've seen some finger amputations, but I don't even remember, unless it's trauma. Remember, we are not talking about trauma here. Here we're talking about atherosclerosis and PAD and plaque and diabetes. I don't think I've ever met someone in 26 years of doing this that has lost their arm because of these conditions. I've seen people that have lost their digit, but not their arm. We don't have as robust of a program around that because it's just not enough patients. But because of our reputation, it is not infrequent that we put a team together to address those patients, because they're very complicated. So it's usually plastic surgery, vascular surgery, and our team, myself, and wound experts discussing those patients that are at risk of losing a digit or have arm ischemia. But thank God there is not a lot of them out there.
Aside from your institution of a multidisciplinary review of individual patients, is the team also evaluating preventative technique and the medical device best practices for adoption to both reduce patients with late stage presentation with advanced disease or to improve the patency rates of grafts?
Okay, I love that question. And Monica, you know where I'm going. You are well aware of our cinema program. And, so we are, I love these questions, by the way, are amazing. I'm so grateful I'm here. So you hit the nail on the head, to be honest with you. I mean, I would love to be out of business and don't have to deal with anyone with gangrene or ulcers. And I didn't have to show you those pictures I showed you in my presentation. So we need to put our energy and our efforts in prevention. So one of the things we did here at UH is that we created a program called Cinema. And basically, Cinema is another multidisciplinary program dedicated to patients with diabetes and PAD from a prevention standpoint. So they don't do any surgeries, they don't do any stents, they don't do any bypass. All of their focus and their energy is around prevention. Prevention, either to prevent you from getting the disease, or if you have the disease or the condition, we want to make sure, all of us, that we are controlling your diabetes, controlling your cholesterol, controlling your blood pressure. If you're struggling with the smoking, help you to stop smoking. If you're struggling with weight, help you with weight reduction. So Cinema is an group of expert cardiologists that are working every day. And every patient I see, I refer to Cinema, because almost all of my patients have diabetes and they have vascular disease. And that's their area of expertise. And as a matter of fact, we are working to recruit even physicians that are just dedicated to seeing patients with ulcers and gangrene and diabetes, so that they can just focus on this population right now as part of Cinema. And we will continue to invest in that program. But yes, we have the Cinema program. You can look it up. It's like cinema, like movies, and it's on the UH website, and is dedicated to patients with diabetes and arterial disease, PAD, and coronary artery disease.
I'm glad you brought up smoking. This person wants to know, patients who are smokers, are they eligible to participate in revascularization, and what would be their estimated success rate?
Yes, that's a great question. And despite the fact that we have gone through medical school and residency and fellowship and a lot of training, honestly, sometimes we don't know how to speak to our patients. And part of the challenge is that smoking is sometimes not by choice. I know it's at the end the choice, but it's a disease. It's an addiction. And a lot of doctors honestly don't have the training, sometimes they don't have the time, because they have to see so many patients. Sometimes they don't have the training, and they don't know how to communicate with the patients in regards to smoking cessation and how to help them quit. I think every patient probably knows the risk. It's just that addiction and overcoming that addiction. We are fortunate. We have a smoking cessation clinic here at the part of Harrington Heart and Vascular Institute here at UH. So every patient that I see that is a smoker, if they are willing to, I refer them to the smoking cessation clinic. Now, that's part of the answer to that question. The bigger part is this. When I see patients that are smokers and they come to me and they need revascularization, I have a heart-to-heart conversation with them. And the conversation I have with them is that there is no way that you can win a basketball game with one player, even if you have Michael Jordan. There is no way. You need a team. And part of the team is the patient. So if I have a patient that smokes and I go in there and try to revascularize them, put a stent or do bypass, that revascularization will not work. The smoking will damage the revascularization and make the revascularization fail. So if the patient is really motivated and interested in saving their leg and they want the procedure to work, they have to work with me to help them and together to stop smoking. And that's the conversation. So can we do revascularization when people smoke? Yes. Is it ideal? Is it a good idea? No. I know I gave you a long answer to a yes and no question, but it's more complicated. So can we do it? Of course we can. Is it ideal? Is it something we like to do? Is it appropriate? Well, it makes it hard, because we know that if we do it, it won't work well, and that most likely is going to fail. And at the end, the person that's going to suffer is going to be the patient. So we try to work intensely to try to help our patients quit. Sometimes it's challenging, and some patients have thrown tomatoes at me, but that's okay. I'll deal with it and continue to engage them and help them quit.
What's the one lesson you learned through all of this that you didn't anticipate?
The emotional aspect of it, Monica. I'm sorry. I'm very sorry. I love what I do. And when I fail to save a leg, believe me, it takes a toll. It really has become a part of me. And that's been the hardest part. I'm not the kind of person that leaves the work and just leaves it there. And that's been the most difficult. I mean, yes, it's long hours, it's a lot of studying and hard work to learn the techniques and the commitments. But if every case was successful, it'd be awesome. But when you lose a patient, you lose a leg, and people travel, I mean, just today, a patient called me from Florida, and they want to come here for me to save their leg from Florida, from Miami. And sometimes we cannot do it because it's too far gone. It's too late. The patient was referred to too late to us. And that's part of the awareness campaign. That's why every time you talk to me, I say, ask for second opinion, ask for third opinion, because a lot of times by the time the patient asks for a second opinion or a third opinion, it's too late. And they come to me, they have traveled, they have flown with their, gangrene and ulcers and their wounds to come see me. And I have to tell them, no, that's the hardest part of my job.
Are there other areas where you've started multidisciplinary programs or where you wish we would see multidisciplinary programs?
Yeah, I think that these are programs that we need to have, broadly across medicine. As you know, cancer doctors, do a good job of this. I think they have tumor boards. And, I have learned a lot from them, to be honest with you. In other areas of medicine, I think we are behind. We need to invest and we need to do this. In heart and vascular, we have created at least 10 programs like this because we are very passionate about this. We really truly believe that nobody knows it all, and that anytime we put a team of experts together, the answer is always better because everybody can have something that they can add. Somebody can look at something in a different way. That when we work in silos, there is something that's missed. So because of that, we have 10 programs here right now. LSAC is one of them. We have other programs that we have created. There's 10 of them that are multidisciplinary. They have surgeons, interventionalists, cardiologists, internists, emergency doctors that work together to try to address a disease process. Sometimes it's related to aneurysm, sometimes related to conditions like hypertrophic cardiomyopathy. So these are different conditions, and we have felt that these are complicated conditions and they deserve a multidisciplinary team to discuss the patient. So yes, the answer is yes, but I think there is many other areas in medicine where we could do a lot better if we had these teams that are multidisciplinary.
Are you using the EHR to automate a requirement for the cinema or multidisciplinary consult before a clinician performing procedures, sending alternative referrals, or placing a diagnosis of PAD in the system as a means of requiring implementation or standardized quality care?
Yeah, another great question. And as you know, we are very fortunate now. We have Epic here, and our electronic medical records. While they make the doctor's job sometimes hard, they have a lot of benefits. Including what our colleague here is mentioning. We do have what we call pop-up, information. In medicine, still there's some bureaucracies that we have to deal with. Going back to earlier conversation about CMS and mandating, kind of some features. Some of the things that need to be policy related. But we do use the medical record to identify patients that are at risk and try to invest in those patients and try to reduce their risk. Do we have a mandatory Epic medical record for PAD referral? No, we don't have that yet. But do we have the LSAC, and do we mandate that people call us if they're going to do a major amputation? Yes. I think what our colleague is asking, can we move the needle to the more proximal, closer to the to the earlier disease stage. Rather than waiting until people need an amputation to activate the LSAC, can we activate these teams much earlier on before they even have a wound or gangrene? That is noted. That is in our mind. We want to do that, and we have, and Monica has covered this too. This calcium score is a perfect example, to be honest with you. Is identifying early disease and then referring those patients to the right specialist and the right team to prevent those patients from getting more advanced disease like atherosclerosis, requiring stents and bypass, or God forbid, getting a heart attack. I mean, that's the whole point. It's the same thing with PAD, is that identifying patients early on with PAD and then intervening with programs like cinema and prevention so that we control the disease before it gets to a point where somebody has an ulcer or gangrene and then they need to come see me and have to get revascularization or, God forbid, undergo amputation.
Yes, and for those who don't know, University Hospitals offers free calcium score tests. Doesn't matter where you go. It takes all of 30 minutes, less than the time in the scanner is probably 30 seconds. And I had mine done. Thank you, Dr. Shishehbor, for watching and scaring me and laughing. All right, Dr. Shishehbor, any final thoughts? I know we got to get you back to work. Any final thoughts you want to leave, especially the medical students, with?
Well, I want to tell you that, I know there is sometimes medicine gets a bad rep these days. The doctors are under a lot of pressure. You hear in the news, I'm sure everybody here has heard that, the burnouts and the impact of healthcare on doctors, the COVID era, and the whole system, not just doctors, nurses, and, our allied health colleagues, everyone in healthcare. I hope I leave you today with that the patients need us. And we need passionate doctors. We need people that are dedicated, committed. You have no idea the gratitude that I get from the work that I do. I would do it. People ask me all the time, would you do it again? Without a shadow of doubt. And yes, there are times that I'm tired. There are times that I'm like, what was I thinking? But I can tell you overall is an honor and a privilege. And I hope that all of our medical students continue to work hard. And I'm grateful that they want to pursue a career in medicine. There is a lot of work to be done, and there's a lot of need out there. So we are all waiting for you. And hopefully by the time you guys are up and running, I can retire and we can take the flag and move it forward.
We're very fortunate to have passionate doctors like you out there, Dr. Shishehbor. Thank you so much. All right, I'm going to hand it back to Dr. Langell.
Thank you for joining us for Vitals. We look forward to seeing you for next month's presentation. Visit neomad.edu for more information.
This is VITALS, Visionary Health Leadership in Action.